Today we're going to talk about the impact of future cuts to Medicaid and SNAP, particularly in rural communities, and how those things will filter down in those areas. So I think we'll just start with some quick intros. I'm Renuka Rayasam. I'm a senior correspondent at KFF Health News, and I'm based here in Atlanta. And we'll start with Gina.
Hi everyone, good to see you. Glad everyone's here safely. Gina Plata-Nino, I'm the staff interim director at CRAC, which is the National Organization that works on nutrition-related poverty issues.
I definitely need the mic. Kevin Bennett, I'm a professor at the University of South Carolina School of Medicine and director of the Center for Rural and Primary Healthcare.
Good morning, everyone. I'm Katherine Hempstead. I don't know if this works or not, or if I need it. Thank you. From the Robert Wood Johnson Foundation. Good to see you all.
So I think, what we're trying to take a look at today is the tax and spending. We're actually, I've always struggled with what to call it because I don't want to call it the one big beautiful bill, and tax and spending legislation isn't perfect either. But we're taking a look at the tax and spending legislation that was signed into law on July 4th by President Donald Trump. And I wanted to kind of start, before we sort of talk specifically about the impact in rural areas, just talk about the legislation itself. There's a lot of, we talked about this in our kind of prep call, there's a lot of complexity in terms of implementation. But can you talk about what this legislation actually does? Because the GOP is saying these are not cuts, we're making these programs stronger, and we are, we're kind of making all these changes, but they're not cuts. And so maybe we can start with Gina, and can you put in perspective what's actually happening in this legislation, what it does to SNAP, and is it in fact a cut or not?
Well, it was $196 billion that they cut off the program. So we'll start with that. Anytime you take away resources, anytime you make things more administratively burdensome, it is a cut. It does a couple of things. For the first time in history, individuals, states are going to have to pay a cost share of the benefit. The cost share of the benefit is, historically, SNAP has been utilized. 100% of the benefits goes to the state, meaning they go to the state, they go to the recipient, and it goes into local economy. States are going to have to pay a portion of that, and SNAP has never been a line item budget, which means that states are going to make a very difficult choice to figure out, we need to figure out how do we restrict people from accessing this program because we cannot afford it. On top of that, they're increasing the amount that states have to pay in administrative costs, which again, states are going to have to figure that out. And as a whole, they expanded the folks who have to meet these really work requirements, that if you can't show that you're working at least 20 hours a day of paid work, you're going to be cut off. And there's so much data. For years, we have seen that it doesn't work. So we expect about 2 to 3 million people who will be cut off from benefits just on this alone, among other things. Right away, also, humanitarian-based lawful immigrants also have been cut off, which again, it means less resources going into the states, and all of these provisions means more work for states, which they can't focus on eligibility. So as a whole, you're going to have a person who all of a sudden has less resources because they took the internet deduction, has their SNAP will decrease because she can't apply for fuel assistance, doesn't count. And all of a sudden she's retired at 62, and guess what? You're on unlimited income, you can't show that you're working for at least 3 months, we're just gonna cut you off, right? So all of these things means cuts, and it means least resources to states, to cities, and to individuals.
And Katherine, maybe you can talk about what the changes are to Medicaid in this bill in particular.
Sure, yeah. I mean, this bill is a historic cut to the Medicaid program, and I also want to point out that as part of the bill, I know we're focusing mostly on Medicaid today, there are a number of different kinds of policies that really make it more difficult for people to enroll in the Affordable Care Act individual marketplace. And at the same time, this is not strictly part of the bill, but as a sort of an important sidebar to it, the enhanced premium tax credits are going to expire at the end of 2025 unless Congress acts. And as of now, there's no sign that they're going to act. So I think on net, one of the things about this bill that's really important to understand is that it just has a catastrophic impact on health insurance coverage. The Congressional Budget Office estimates that all in, everything, the bill and the enhanced premium tax credits, something like 17 million people will become uninsured over the next 10 years. And, you know, just for context, there's something like 30 million people uninsured now. So that's 40-ish% increase in the size of the uninsured population if this all, you know, comes to pass, and you know, the impact that's projected is what happens. So that's huge, and that means a lot less revenue for healthcare providers. So I think when we think about the impact of these Medicaid cuts, you know, in rural areas and in any areas, like, it's important, I think, to think about it in the context of a really massive coverage loss, so that lots of other people are losing coverage besides Medicaid. And in terms of Medicaid, I think the thing that like a way to kind of drill down what's important in the bill is that it sort of goes after two big things in Medicaid. It has a set of restrictions, well, three things if you count some of the anti-immigrant provisions, which is sort of another issue, but there's a set of reforms that are designed to make it harder to stay eligible and receive Medicaid, and they're really targeted at the Medicaid expansion population. One of them is work requirements, which is something that a few states have experimented with in the past, but this is really historic to have a federal mandate to have work requirements. So that's a huge thing, and there's, you know, projections, I'm sure you've seen and written stories about it, that, you know, millions of people will lose coverage, and most of those people will in fact lose coverage because they're not able to comply with the requirements. And then another related and, you know, related in spirit, but maybe less massive in impact, is to increase the frequency of eligibility redeterminations, again, for people in the expansion population. So this is sort of like putting sand in the gears and just making it harder for people to stay in their coverage. So that's like one category is a set of things that go after people and make it harder for people to keep their coverage. But then the other thing that's really important too is a set of policies that make it harder for states to use certain financial practices to get more federal money into their Medicaid program. And this is like a little bit in the weeds, and it's not equally important in all states, but it's these state provider taxes and state directed payments that allowed states to, you know, kind of leverage some provider resources to get a higher match. And it's important in most states. It's more important in some states than others. So that's something that's not going to go after people, but it's going to go after money. So when you hear people say, oh, these cuts are going to affect the elderly and the disabled, and you might wonder, well, why? They're not subject to work requirements. It's because a lot of the services that they receive are sort of discretionary and optional, and when states lose Medicaid funding, they have to try to cut corners and fill gaps. And so that's why the whole Medicaid population is really jeopardized by this policy.
And let's set the stage here for a moment. So Kevin, can you start, I want to start with, why are these programs, SNAP and Medicaid, why are they so important in rural areas? Or what is their importance in rural areas? And can you sort of put in context, you know, when it comes to rural health, when it comes to the demographics of rural areas, just the importance of these programs?
Yeah, I think
Can a little bit.
there's a lot in that question. And I appreciate what you were saying about, I think people are focusing on the loss of insurance coverage for folks, and that's a huge issue. And in rural areas, there tends to be a higher proportion of uninsured and Medicaid covered entities, especially dually eligible Medicare and Medicaid. And you start having higher uninsured rates, you have more uninsured folks going to rural hospitals that already have negative margins, and we're going to start seeing some drastic cuts to services, possibly closures, those sorts of things. I think most alarming, and it is in the weeds, but those state-directed payments are really going to have a huge effect on rural hospitals. A lot of states, our state included, uses some of these state-directed payments in specific programs to keep rural hospitals open. And we're looking at reductions of about $2 billion a year in our state to hospitals, billion with a B. We don't have that many hospitals, and that's going to really, really hurt. And to say rural communities depend on Medicaid is not an overstatement. It keeps the doors open. It keeps people insured. Employment is different in rural communities. You don't have, corporate jobs in rural communities. Sometimes you do, but, it's harder to find. So Medicaid is definitely a safety net for those folks who fall through the cracks because of the way the system is set up. I think it's also really important, especially for you all as journalists, to really try to tease out the differences and the nuances in this bill, which we call it OB3 now, if you want to use that, which feels kind of Star Wars-y. But it really is directed in kind of two different ways. One, it tends to be very punitive to states that expanded Medicaid. So ironically, in South Carolina, it's not going to have a huge impact in a lot of ways because we aren't an expansion state. So those work requirements only apply to the expansion population. The state-directed payments are going to really hurt us and everybody equally. And it seems to be this idea, and you heard a lot of this fraud, waste, and abuse idea that we're not cutting Medicaid, we're getting rid of fraud, waste, and abuse. Well, they didn't really do that unless you talk about the 6-month renewal cycle, which could eliminate some fraud or abuse, but not likely. It's just going to churn people out because they don't have the documents. I think there's a viewpoint that anybody who's not a woman, child, or with a disabling condition shouldn't be on Medicaid, and it's fraud if you are. I think there may be a thought that if you're a hospital and you're getting extra payment through the Medicaid program, that's fraud or abuse of the system in some way, shape, or form. So they cut those out. So it's a framing issue, and I think what we're trying to do as people who know a little bit about this is try to reframe it into you're reducing payments to safety net vulnerable populations and providers. We need rural hospitals to keep people alive. Casey did a good job of pointing out where do we get our food from, our fiber, our fuel, even our fun. Rural is vital to this country, and it's not fraudulent to figure out how to keep rural hospitals open. It's very vital to what we try to do. So yeah, I think with reductions in insurance, reduction in payment rates, these sorts of things, even with the SNAP benefits, you're going to see rural communities reducing services, maternity closures, hospital closures, clinic closures. Once you see a hospital close, and Casey talked about this as well, you kind of see a cascade effect. Doctors will leave, businesses will leave, people will move, economic kind of goes downhill. So it's extremely vital to our underpinnings of our society, I feel like.
Katherine, this is your slide, so I'm going to let you, but before we get to food benefits, I wanted to talk you to sort of talk us through what makes rural communities particularly vulnerable to these changes.
Yeah, and I think this is sort of, I can barely see that slide, but everyone else can, and I kind of remember. Yeah, I mean, I think it's like the bill is going to have a terrible effect on every state. New Jersey says they're going to lose $2.8 billion a year in hospital funding. I mean, every state's going to have a huge impact from this bill. And also, rural communities had a lot of challenges before this bill. So it's kind of the intersection of those two things means that it's a very, very profound effect in rural communities. And some of the sort of context that I wanted to just point out in that slide is that, I think some of these things have already been mentioned, but there's higher rates of poverty in rural communities. So there's more dependence on Medicaid. There's fewer jobs that offer insurance, jobs, more low-paying jobs, and there's also higher use of the Affordable Care Act marketplace, and so that's kind of a relevant thing too. So there's going to be more of a sort of sticker shock for more people in some of those communities when we see those tax credits expire, if indeed they do. In rural population change is not uniform. There's some rural counties that are growing, but some have seen sustained population decline, and a lot of them have seen population aging. I mean, the whole country's aging, but many rural counties are sort of disproportionately aging, so you see a lot of depopulation and geographical isolation, which increases travel distances and, creates another kind of challenge for rural communities. You also see poorer health. There's been a rising rural mortality disadvantage since 1999, and it's really, you can kind of see where it's coming from. There are higher rates of chronic conditions, higher rates of certain kinds of external causes of death like suicide, drug overdose. There are, differences in health-related behaviors like smoking. So there's a really high need for healthcare services in rural communities, but there's Then the next thing I think I wanted to tee up were some issues with the health system infrastructure, which I think Kevin has talked about already. There's shortages of providers, there's less physician per capita in rural areas, and there are some very, very financially fragile healthcare systems. And unlike a place like New Jersey, which is where I'm from and where I worked in the health department, and there were, you could practically go out of your house and throw a rock at a hospital. There were so many hospitals in New Jersey, and a lot have closed, and there's still a lot of hospitals in New Jersey. In a lot of rural areas, there's really, maybe just one system. So you get to kind of a tipping point place where, how can you have a community? You sort of need access to food, water, education, maybe some local business and healthcare. And if you get to a point where people have to go too far to get access to healthcare, it really calls into question sometimes the viability of rural communities. So the need is greater, and the issues become sort of more urgent in rural communities. And that's, I think, the kind of context that we wanted to
And
point out.
one thing I hear a lot too in my reporting is in urban areas you have, hospitals, providers. You have a different payer mix because you have a lot more people who have employer-sponsored healthcare. So Dallas, for example, there are a lot of jobs. You have, hospitals can survive because you have a lot of people who have employer-sponsored healthcare, so they can write off the sort of what we call uncompensated care costs, which is somebody goes to the hospital, they don't have health insurance, and they can't pay, and the hospital has to write that bill off. And in urban areas, hospitals are getting more people with employer-sponsored insurance, but in rural areas, you don't have as many people, you don't have as big of a sort of financial buffer as well, right?
That's correct.
Yeah. Gina, let's talk about SNAP or food benefits. I think about rural areas, I think about a lot of agricultural areas, but these are areas that are really, really dependent on food benefits, right?
They are, and I'll invite you to go to the next slide.
Oh, yeah,
I
okay,
think that provides a better picture, and I think you set it up. Rural areas have a higher rate of poverty, have a higher rate of food insecurity, and a higher rate of SNAP usage. So the impact that you were mentioning, we're going to see it at the SNAP level. And when you think about the connection between SNAP and healthcare, one of the things that we know is that the worst health outcome is what? Hunger. And it causes the economy billions of dollars, hunger-related health issues. So we're going to see less access to that. One of the most detrimental provisions of the bill is, you mentioned the work requirements, which have failed. Many individuals in rural areas do not have access to full-time employment. Time and time again, they say it's because we don't have childcare, it's because we're taking care of an ill family member, and because there's no transportation. So all of these things are not going to change overnight. These time requirements, these work limits don't come with a job offer. They don't come with resources. They don't come with childcare provisions. They don't come with the state to say, we're going to give you extra money to do training and so on. It is so incredibly limited. So what's going to happen to a lot of these populations is, once it's implemented, is within 3 months, if they can't show that they're doing the 20 paid hours, they will be cut off. And the reason why I mentioned the paid hours is because a lot of individuals, particularly women within that new age bracket that has been expanded to 64, provide a lot of unpaid childcare. It's not recognized. There are areas who also do a lot of homeschooling. And so if you have a child that is over 14, the homeschooling doesn't count. And so all of these things, all the providing that you're doing to take care of an ill child, a parent who needs your help, none of that time is taken into account. And these new people, the 54 to 64, and also cutting off unhoused individuals, youth aging out of foster care, and veterans, it's going to be incredibly detrimental. And you're not going to have a healthcare system to be able to assist you. And people are going to, we do know that data shows that people who are on SNAP are less likely to be long-term hospitalized, are less likely to go to the ER. So what's going to happen? People are going to need to go to the ER, but as my colleagues are saying, there won't be a place for them to go. And even if there is, it's not like in other areas where you can be within 30 to 60 an hour. And the last thing I'll say in terms of job, as you mentioned, there are not that many opportunities. And so it makes it a lot difficult. Even like one of the provisions that you can volunteer is difficult, because it's really difficult to volunteer when there's no cash for gas and other things. And the last thing I'll say is that the Medicaid provision and the SNAP provision don't match in terms of work requirements. One of them says, like, you need to show that you are already have these volunteer work hours, and then SNAP is like, no, you have 3 months in order to do this. So there's going to be a lot of confusion, and I'll close with this and this front that as rural areas are going to states who are heavily rural areas with less tax income base, there's going to be less resources to pay for SNAP. And we already have heard of some states that said, look, in 2-3 years, when this is implemented, the cost share, we're just going to pull out. What is going to happen to those families and what is going to happen to the well-being? Because it's all interrelated. And for grocers, the reason why we had put in that quote is people don't understand the interconnection between SNAP and local grocers in the system. What we heard when we were interviewing individuals during reconciliation is like, look, our margin is incredibly small. And 50% of that is SNAP users, particularly in rural areas. But, majority of folks in high need, low food access are in those spaces. And if SNAP cuts are implemented, which they are, we will have to close, which means that place, similar to the hospital situation that you utilize, is if there's no store, there's no tax, there's no wages, and people are just going to move, because if I have to drive 100 miles to the nearest place to get food, it just becomes more burdensome.
Let's now let's kind of talk through. I mean, you've talked through some of this already, but can you, and maybe Kevin, we can start with you. But what are the populations in rural areas that are going to be most affected by these changes? You think, or like if you can kind of zero in on?
Yeah, that's one thing about rural is it's hard to talk about rural as a monolithic type of entity. The populations differ so widely across the U.S. Generally speaking, it's those vulnerable populations, for lack of a better word. In the South, it's going to be African American, Hispanic. Out West, it's going to be different populations. You have more indigenous and those kinds of things. But it's anybody who is, lower income, or as you were saying, working non-traditional, non-paid, unpaid caregiver type roles, family support roles. Agriculture is going to be hit very hard from the SNAP side, but also from the employment side. So, I mean, it's all these folks that are kind of on the margins, right? They're kind of getting by right now because they have Medicaid and SNAP, and they can feed their family. They're not worried about bankruptcy due to a health shot. And if those things go away, those folks are going to suffer the most, and it's going to be really, really hard to really track that. As Casey was saying, data is going to be more sparse, and these are small populations anyway. I've spent 25 years trying to tease out what we call the dual disparity. If you're rural and rural non-white, rural female, rural disabling condition, those are folks that you get to small numbers that disappear in data sets, disappear in county aggregate data, and it's really hard to tease out those impacts. I think one of my greatest fears with all of this is it's going to be implemented, it's going to affect these populations very deeply, but since it's 2-3% of the U.S. population, people are just going to shrug and say, well, I don't really see what the big deal is. These are not folks who have a political voice, a political lobby, they're not on TV, those sorts of things. So it's going to be hard to not have that get lost.
And what does it look like, right? I mean, for those families, you said you spent 25 years looking at this. I mean, what I found in my reporting is that people are very adaptive too, and people survive somehow.
Sure.
But what does that look like in terms of their, like these kinds of cuts? What does that look like for someone's life?
Well, so for those folks on the margin, let's say they lose insurance, either through ACA or Medicaid. They will simply, especially parents, those of you who are parents get this, you'll give up your care in order to pay for the care of your kids. There are free clinics out there. There are providers who will provide uncompensated care, and you'll just do your best. Things that will go to the wayside, I think, first include dental and preventative type things, because those are costly, and you're like, especially for the parents, I'm going to push out my dental screening another year, another 2 years. And then you start losing teeth, and that leads to hunger and other sorts of things. Hard to get a job if you don't have a couple teeth. You'll see that sort of thing. Rural communities are really good about trying to step up and help their people. We see food banks, for example. We see medical clinics coming in. I know in Virginia they do a giant free medical clinic that they started it thinking they would be going overseas to serve underserved and realized they needed to do it in their backyard. So there are ways that help, but those are such Band-Aids that don't cover the systematic problem. And, these folks are going to get left behind. And I think you pointed out beautifully, there's a concept of structural urbanism. I don't know if you've heard that term. My colleague, Dr. Probst, kind of came up with that. Around everything is structured assuming you have plenty of providers, plenty of resources, plenty of ability to do things. And so often rural gets left behind because it just doesn't work when you get down to the rural level. Whether it's hospitals, SNAP, transportation, getting 20 hours, of volunteer time or whatever, it doesn't work. Excuse me. But these things, the OB3 is set up structurally urbanist, assuming you just go to McDonald's, go to Walmart, go get a job somewhere. Well, we don't have that. So these families are going to be left behind. They're going to become, I don't want to say the responsibility, but I think the community will try to step up and help each other out. But you'll see folks moving, like you said, to relatives, to urban areas to try to get jobs there, and that's going to be harder if you can even afford. And how do you rent a U-Haul if you don't have gas money? So it's going to be very difficult.
Housing, yeah. Catherine, I don't know if you want to touch on some of the groups that you think will be affected by this bill.
I mean, I think everything that has been said so far is spot on. I would just add a special consideration or additional consideration of people that are like low-income, elderly, and disabled, people that are counting on getting home and community-based services for Medicaid. I mean, there's kind of like two pathways into Medicaid. One is income-based, and one is, what people call categorical, based on some kind of disability or low-income elderly people that get supplements, to help pay for their Medicare and cover some of their costs, and also pays for nursing homes and pays for a lot of people that need, a caregiver at home or need to get bathed or get services at home. And while nursing home services are mandatory, home and community-based services are optional. So states can really exercise a lot of discretion in how much of those services they provide. And you might also think about like services for people with intellectual disabilities, like day programs or group homes or all those kinds of things. And even now, in every state, there's excess demand. And a lot of people wait on waiting lists, to get a community care waiver that would allow them to not live with their parents anymore and go into a group home, or to be able to have an aide that could take them out into the community. So there's already a huge unmet need for long-term services and supports, but the provider tax part, that wonky, weedy, hard to explain part of the bill that's going to take so much money away from states, and these states, as other people on this panel both have mentioned, these states, rural states, tend to be fiscally pretty constrained. They don't have a big tax base. They can't necessarily raise a lot of money through property taxes because property values are not always rising and population's declining. They're not economically diversified. They don't necessarily believe in having high taxes, so they don't have good ways to fill those gaps. So I think if I were a reporter covering this story, one thing I would be really interested in looking at is like what is happening to state Medicaid budgets and what kinds of cuts are states making in places that they can cut. Kevin mentioned dental. States could cut dental as a Medicaid service, and vision, and they could cut, sort of the quantity and quality of programs for people who are categorically eligible for Medicaid. So you might see longer waiting lists, and so I think that's a good place to look also for kind of stories about how this bill might impact people, even though it's not the people that we think about maybe first who have to comply with work requirements or, do eligibility redetermination, and that's something that will affect every state, because every state has to deal with home and community-based services. So I think that's just enough. And then I would just also say, and I think it's really been said, like when there's a massive coverage loss and a withdrawal of funds from hospitals, it ripples throughout the whole community. If a hospital closes or reduces services, it affects everybody, even people that had employer-based insurance, now they have nowhere to go. And you'll see people maybe get laid off from hospitals that are closing or reducing services, and you'll see more medical debt, and people won't be able to pay other bills like their rent and stuff like that. So there's a huge ripple effect. And when we expanded Medicaid, we got to see how much it helped, when people had the coverage. And there have been really good studies that showed not just did cancer deaths go down and things like that, but people's rates of personal bankruptcy, all those kinds of social and economic measures improved because people had this really important source of financial protection. And now we're really throwing that into reverse, and we're going to see everywhere, but I think really, especially in rural areas, we're going to see what happens when you take that financial protection away.
Yeah, I wanted to get to the ripple effects. I think that's so interesting because it's something that I've heard a lot when I was talking to somebody in Alabama. They were saying, yeah, like, these hospitals, people with employer-based insurance are going to see these effects too or with commercial insurance, because prices will go up as more people are uninsured, and providers will close down, and they're not going to have a place to go too. But I wanted to talk about that with SNAP. I mean, you touched on this, Gina. So some of the populations are affected. So I'll say, you said, so work requirements are now expanded to people who are homeless, veterans, former foster care youth. I believe like indigenous people will gain, is that right, or gaining?
For some of them. There's like 2 provisions from like California.
Okay. But just talk about the ripple effects. You touched on this a little bit with grocers and stuff, but yeah.
And I think you did a very good job of saying it. Think about the state budget, and I have to go back to the state budget because while this is a federal issue, it's states, and states are not all created equal and don't have the resources. Our states have depended on federal funding from ARPA, from other sources of funding, and for the first time this year, many states had to struggle without like the COVID pandemic era. And if you look at the state budget, 30% nationwide is for Medicaid. The other biggest pocket is K-12 education and all the other services. SNAP's not there, right? But it does bring in money. It brings in billions of dollars into the economy because, like I said, it's a pass-off. Like individuals get it and they spend it locally. People are going to feel it because guess what? The grocers closed, that community that you're part of, that grocery store closed, so that means less income. I'm not going to get the school bus that I needed. I'm not going to get that special ed teacher that I needed in that town. Cities and municipalities are already saying, we held reserves in case as anything happened with HR 1 or OB3, how you want to call it. So they didn't utilize it. Innovation has stopped. States are now willing to spend on other things that are needed. And what we are most concerned about is K-12 education, which is like the other biggest pocket of how is that going to be utilized. And, what are public services? Because yes, it's bad at a state level, but the more you get into little cities and municipalities and towns, there's less resources there. And some towns will be okay because they won't feel it, but others won't. But as a whole, construction will stop. I believe it was Iowa who dipped already into their reserves. Like if you don't have reserves, then you don't have a good credit score, so you can't do construction, you can't get lending. What does that mean for your state? And this is all before the implementation of these cuts. So we're going to see these states making very, very, very difficult situations. And for us, the way we track it is, again, it's just not the grocers. Is other things in place that no longer are there. That grocery store leaves, other businesses close, and then the workforce is sick because they don't have resources. And the price of food is increasing. But if now you have to drive 100 miles, your food is more expensive. And I know a lot of people are like, oh, there's food delivery. That comes at a cost. And it is not delivered in rural areas. I always have to push back on that because people are like, well, there's, these many companies who are doing it. I'm like, oh, no. There's an extra $30, $50. And when you're on a budget, those $30, $50, and they may not come to you because there's just not enough, right, for individuals to go in those places. So your food, your bag of potatoes, instead of costing $8, are now going to cost $20, which is money and resources you don't have. And for SNAP, we have plenty of data to show that people are more economically viable because 80% of folks' income goes into rent. Rent is not going down, nothing else is going down, but all of a sudden my food budget is gone. What does that happen? What does it mean for individuals? Okay, I'm going to have to eat less. And for parents who all of a sudden are cut off, yes, their kids can get it, but they're not going to have they're more likely to get sick because they're not getting the nutrition that they need. And so all of this is just affects at a very individual, but also at a wider level. And the cities and the municipalities is something that we are most concerned about because they're the ones who have to see the faces of individuals and figure out their tax base and how do you address this gap that is being left within these spaces.
That's why my husband won't let me do grocery delivery. But like, so one thing I want to talk about, which you haven't touched on, is sort of related to this, but something like summer EBT. A lot of states have opted out of this, right?
Yeah. So Texas was one of the states that said, listen, even before HR 1 passed, they said, we can't do this because we don't have the money.
So these are summer programs to feed children, right?
During the school time. And there's money. The federal government pays 50%, states have to pay in 50%. And it is, a cash benefit for kids who are in school from K to 12. And most states, some majority of states have opted in, but some states are wary because they're like, we don't have the state budget. And I'll bring another point. Some states have universal school meals, right? And breakfast, because that's important for kids. One of the error rates for one state, for example, ends up being, if they have to pay a cost share and administrative cost, almost $500 million that they will have to come up with. The coverage for the universal cost meal is $280 million. What sort of decisions our states are going to have to make? Do we keep an optional program or do we keep a program that brings in? And that's not just like I said, one state has already said, we'll in about 2 years, we'll just pull out of SNAP because it's not mandatory. You don't have to run SNAP in your state. It's an option to do so. So we heard from one state already said that, other ones are figuring out how to actually decrease categorical eligibility in our space as well, which will also cut off more individuals and allow for like summer EBT, summer meals, breakfast after the bell, all these other child nutrition programs to be impacted. And think about the community eligibility provision. I will look into that too. States pay or cities pay based on how many people are enrolled in certain services, right? So if you're not enrolled in SNAP because you're being cut off and your city doesn't have those numbers, that means the city has to pay more. So if you have a high priority poverty area, it might be 100% covered or 80% covered. If that decreases in terms of enrollment, now your city is going to have to pay for those school meals, instead of paying 20 cents to the dollar, now you're paying 40, 50, or 60 cents to the dollar. And for again, a municipal level, that is quite a hit that they are not counting on. So there are many impacts to child nutrition programs that we are looking at as well that this bill will have.
I hate to think about this, but does that just mean kids are going to just have no meals or one meal a day or something?
Some states, look at Texas, right? Just because the governor was just so vocal about that. There's no provision during the summer. And we do know that kids who are hungry, have disciplinary issues, are less likely to complete school. There's so much detail on what all of these child nutrition with SNAP provides for a child that they're less, they're more likely to graduate. They're more likely to enter the workforce. There's so many health and well-being benefits that if these harms do come in terms of access, we're going to see a new generation of children who don't have the resources to be able to complete school and have the well-being that they need.
I want to leave time for questions, but I just have a couple more of my own. So Kevin, I want to talk about the responses too. That's sort of up here as well, and Catherine, we can talk about that. But what would structural ruralism look like? Sorry, that's a hard word to say.
That's a good question. How much time do we have? I think there's a concept out there about treating healthcare as a utility instead of a commodity. Why aren't we paying for, as a society, to maintain a certain set of essential services everywhere, whether it's primary care, trauma care, pharmacy, mental health, health-related needs like transportation and health. We do it with schools, we do it with water, sewer. The community pays for the pipes, and then you pay a use fee on top of that. And to me, that's structurally rural, where we can set up a service, obstetrics in a county, and no, you're not going to have as many women, but at least it's there for when you need it. Primary care, pediatrics, pharmacy. And the volumes are going to be lower, but everything we do is based on volume and fee for service, and that just doesn't work. But every other country in the developed world has figured this out, that we're like, okay, this is something that helps our society. Study after study shows if you have health insurance, you're more likely to work, your grades are better, your productivity is higher, economic return is higher. It's an investment in our community, 8 to 20-fold, depending on the study. That is what I think we should see. I just worked with a panel last year. We called it the Future of Rural Health. I was with Rupri and a couple other folks, West Health, NRHA, and we kind of released that roadmap of what that would look like. And that was part of it. Capacity payments, standby payments, utility type setup, essential services at the local level, regionalization of more intensive acute care. We don't need a trauma one everywhere, but we need to be able to get to it, right? And then we need to refer back. But connecting with the health-related needs. If you're hungry, you're not going to worry about your diabetes. So how do we fix the hunger? If your apartment has mold, you're not going to control your asthma. So how do we fix those things and actually work towards the health of the community?
Sounds simple.
Yeah, easy.
Katherine, can you talk about some of the responses to?
Yeah, I mean, I can't resist just jumping in on what Kevin said, and it also made me think about the universal school meals. I think one possibility is that this will kick off some bigger conversations about, I think that in the short run, everyone's sort of trying to minimize the damage, and I'll get to that in a minute, and sort of get back to what we had or keep what we had. But I think it's also going to hopefully make a lot of people across the political spectrum, if we see some of the impacts that we fear are going to happen, think, is this really the best system that we can come up with? It's so inefficient. And when you look at like universal school meals, it's a great example of like, okay, everybody has to eat, all the kids have to eat. The current systems can be so complex, kids get shamed for not having their lunch money or this or that, and really you could finance this in a much more efficient way if just everyone was universally eligible. And, you can think about that in terms of healthcare too. And I think one of the things that's going to come out of this is, more people are going to be aware of how complex and fragmented our healthcare system is, and how there are all these different eligibility things that people have to jump through, and that we actually spend an enormous amount of money and time dealing with eligibility and enrollment. And if we had more universal eligibility for services, that would be a way to have a more efficient system. But we need to figure out a way to do it that can have a sufficient amount of consensus. And what we've seen clearly in this bill, and I think that would be wrong not to learn the lesson, is that there was really a renunciation of some of what had been achieved, and there's been this sort of lingering ill will about expansion Medicaid that has emerged again here. But in terms of short-term responses, I think one of the things that is fun to track, or not fun to track, but important to track, is what's actually happening with your local health system. So I put up a map, and it's kind of the perspective is weird because Canada and Mexico look larger than the U.S., but it's really a map about the U.S. and it's put out by Protect Our Care.
Sorry.
And it really, no, it's me. It was my fault. I am a bad Zoomer. Protect Our Care has a tracker called it's called Hospital Crisis Watch or something, where they have these hospitals that the Shep Center at UNC says are in danger of closing, and they are updating that. And they actually had a press conference a couple days ago with Chris Murphy, where they unveiled this tool. I'm sure anyone can find it, but it also, if like me, you're map challenged, there's a list with all the hospitals, so you can look in your community and say, okay, these are the hospitals that are considered to be vulnerable, and that would be a good place to look, I think, for stories. I mean, I think looking at individuals that are going to be affected is really important, but then looking at healthcare providers is another good way to sort of communicate to the public what's going on and what's at stake with this bill. But the other thing I really am supposed to talk about now is responses, and I think that is a very interesting and rich area. So one category of responses is thinking about quote unquote harm reduction, because as we've said, a lot of the people that lose their coverage due to work requirements I'm sure it's true in SNAP, it's definitely true in what we know about Medicaid, is through kind of errors or people being unable to successfully document their activities. And the research that we have done, and it's limited, but the research that we've done on pilots that have happened suggests that the majority of people that lose their coverage are actually eligible. So that's terrible and sad, but it also suggests there's a pathway to improvement, right? Like if you could really implement this program perfectly accurately, you would have much less coverage loss. So I think that that's set off kind of a cottage industry of, vendors, people, tech people, states, everyone kind of thinking about what are some ways to do like harm reduction so that we could actually implement this program in a way that would not lead to all this sort of collateral damage and, inaccurate coverage loss. And the same is true with eligibility and, eligibility and enrollment redetermination, that increased frequency of redetermination. So that's something that some states are getting more into than others. I think it depends on the sort of the politics of the state and how much the state may feel like they are on board with this bill and how much the state is, very clear that they oppose this bill. So obviously there's a little bit of a red-blue divide, but I think that like a lot of states, even if they're red states, don't want to lose this 90% federal match, and they would love to find ways to, not have people lose their coverage because, then they're going to show up as charity care, or their hospitals are going to lose revenue. So I think every state is secretly interested in this issue. Every expansion state. This is kind of an expansion state issue. But I think it's a little bit of a cagey thing because we're waiting to see how CMS is going to lay out the rule for how you have to do it. So I don't think anyone wants to be like, hey, I have all these really great ideas about how we could minimize coverage loss, until we sort of see what is CMS going to say? What are the opportunities for state variation? There's a concept called medically fragile. If you're medically fragile, you're supposed to be exempted from work requirements. Well, that can mean people that are in substance use treatment. It can mean quite a few different things, So I think there are places where states are looking to see how can we do this so that we don't make the same, colossal mistakes that it seems like every other state made that ever tried to do this. Whether you agree with the concept of work requirements or not, there are ways to do it that results in more or less coverage loss. So I think that that's like a really big thing. On the state-directed payments and the provider taxes, there's a furious amount of lobbying going on right now, and I think that would be an interesting issue to follow too, depending what your beat is, because you might remember if you covered the Affordable Care Act, there was something in there called the Cadillac tax, and it never was implemented because the different interest groups lobbied so hard for it that ultimately it was delayed, eliminated. So nobody's saying that's going to happen, but I think that that's something to watch. Like how much are, behind the scenes are people trying to delay, reduce, erode, avoid the impact of some of those taxes. And that's got a really big impact on all states, but that's something that's, especially the non-expansion states, that's what's going to hurt them. So I think that that's, that's a really important thing to watch too.
So, go ahead. So I want to open it up for questions, if that's
okay.
I'm
sorry.
Because we just have a few minutes left, and
bad.
Kevin has to catch a flight. So I wanted to ask you one last small question, Kevin, before we leave, which is we talk about these changes as really subtle, really nuanced, really complex. Data's not hard to find. Sort of your parting thought before you have to go catch your flight. How can journalists write about some of these things? That's something that I'm struggling with too right now.
Yeah, I think what you said it best. Contact your local system, your local providers, and find out what's going on. I think what would be interesting, I want y'all to keep covering the downside effects, the negative effects, because that's important. But also trying to tease out what systems, what programs are doing a really good job of responding to it, staving off the changes, and maintaining services, and how they're doing that, and spreading that message as well. It would be really good.
I'm going to let you go, and then I'll start with questions, because I really don't want you to miss your flight.
And Google me and email me.
Yeah.
I can share Kevin's
just
contact
one real
information,
quick
too.
reminder. The next session is going to drill down on the Medicaid work requirement. So for just to sort of shape the Q&A.
Yeah.
Thank you.
All right.
So, Sophie, do you want to start?
Thank you all for having me.
Oh, Ariel?
Thank you.
Nice to meet you.
Yeah, well, I was going to have a question for, but I will, Ariel Hart, I will be emailing you.
I have 2 minutes. Go ahead.
Yeah, so I know that we're about to have a session on work requirements, Catherine, but you two have a little bit different expertise on that. And I wanted to ask, so I work in Georgia. I spent a week once trailing a woman who was trying to just figure out if she was qualified for Medicaid or not. She was going to offices that were closed when they said they'd be open, et cetera, et cetera. So one thing I started to wonder is when I talked to Governor Kemp's office, they have come around to wanting this to work. They want to claim a success. And I just wondered, like, what would it cost if you really wanted it to make a success? If you wanted to have the, maybe Deloitte or who changed providers, I don't know, build that kind of computer system that works as well as PayPal, staff the center. Do you know what it would cost?
No. A lot.
They spend a lot already. There's spy. Georgia is a good example, a good recent example of a state that spent a lot of money developing a system. And unlike other states, it was designed to let people in instead of potentially kick people out because it wasn't an expansion state. And the results have been that so few people have been able to navigate that system and get coverage that they, I think, reduce the frequency of their eligibility tests, and I think they probably did spend a lot of money on a system that didn't work that well. So I don't know how much they'd have to spend.
I'm looking if anybody's knows who to ask because they actually didn't build a new system; they added onto it.
That's good for next panel. I want to get to the other questions before, if that's okay. So, Sophie, do you want to?
Sorry, I hope you're not being cut off. So there's been a lot of talk recently about how many able-bodied adults there are that could be working when we're thinking about, I heard a farmer say this the other day, like we have so many able-bodied people receiving Medicaid, receiving SNAP, like why aren't they in the workforce? Who are we thinking about when we're talking about able-bodied adults receiving Medicaid and SNAP?
That is, I always want to ask, who do you know that is within that space? And I think that the data, it shows that, again, that these are individuals. Able-bodied adults came from 1996, the Personal Responsibility Act. Originally was for individuals who were 18 to 49. 2023, it expanded it to 54 and then to 64. The population is so completely different since 2023 because, again, these individuals are gig workers. We have rural economies, you depend so much on the gig economy, on part-time. These individuals are working. They just can't show enough hours, or there are verification issues. There are childcare issues. There are so many obstacles along the way, and not all of them are able-bodied, which again, the language, many of them do have disabilities, but proving disabilities, it's now going to be even harder as, healthcare closes and it's more difficult to prove that, any sort of physical or mental or disability that is not clearly visible to a caseworker. It's a lot harder to prove in order for people to be exempted from those resources. And who are, one of the biggest populations that we see is the unhoused. It's really difficult to get a job when you don't have access to a shower or to food. Very few people hired individuals within that space. And it's difficult with the transportation is sort of the biggest barrier. So it is a bucket of many different individuals. And we have a brief, so happy to give you a study analysis that they've done on states and who is the most folks that are impacted. It's unhoused and veterans and so on, which is why in 2023 under the Fiscal Responsibility Act, they added those buckets. They're research shows that these are some of the most impacted populations. Let's make sure that there is some sort of protection.
And caregivers, right? I think caregivers is a huge one.
It's a huge one, but even more now because it's expanded to 64, right? 54 to 64 category. Again, many grandparents are now raising their grandkids, but they're also taking care of their children as well because childcare is really expensive. In some places, it is the same as as rent. And so people can't afford it, and it's free labor that it's not counted because when I mention volunteer, has to be authorized by the state agency. It can't just be no, mom, here I write you a note that you're taking care of my child.
Yeah.
That's not that work doesn't count.
And when they lose benefits, their kids lose benefits, right?
Mm-hmm. I just to add on to that, there've been some studies of other states that have had work requirement pilots that have shown 90% of expansion adults are believed to either be working or engaged in some other eligible activity like caring for a dependent child or a disabled relative or have some kind of a disability. And one of the things that we learned, and I think this could be a good story to tell too, one of the things we learned with Medicaid expansion, and there have been some really good studies, including Ohio did a really great evaluation of this, is that people reported that because they got Medicaid, they were able to work, and they were able to be more productive at work because they could take a lot of times because they were able to take a medication to manage a mental health condition or chronic migraines or, eczema or, something that they were able to manage that condition, and that actually enabled them to work. So I think that one of the things that 100% is going to happen as a result of work requirements is that labor force participation will go down instead of up because people are going to lose their health care and then they're not going to be able to work. So there's a sense in which you have kind of the tail wagging the dog, and there's this idea that you have to work in order to earn health care, when in fact really people need to be healthy in order to be as productive as they can be. So I think you will be able to find lots of examples in your communities of people who, because they couldn't document their work activities to the agency due to work requirements, they then are able to work much less because they get separated often from their medication.
We really only have time for one more
Okay, sorry.
question.
Great. I think
One
we
more
have time for
question.
one more question.
Thanks.
Perfect.
Sure. Mine may be a little in the weeds, but one of the things that we're tracking in Michigan is the restructuring of our prepaid inpatient healthcare plans, which is what distributes like Medicaid funding, from the state down to kind of the various entities that offer like mental health services, behavioral health services. And this kind of started before the passage of the one big beautiful bill, but I guess one of the things that I've been wondering, just because I'm laser focused on Michigan, but is if we're seeing other kind of similar restructuring of like the infrastructure in which Medicaid gets dispersed in other states. I just don't really have that context, and I was wondering if there's anything that you've seen like that.
I mean, I think there's always things going on, and I don't know if this is helpful, but CMS has also signaled that they have sort of different attitudes toward some of the like demonstration waivers that the prior administration had. So I think that is another thing that a lot of states are worrying about, that they have a big demonstration waiver that might not be approved when it comes up for renewal. So I think states are probably trying to game out, different strategies to try to keep as much of their federal funding as possible. I know some states are raising provider rates kind of now while they can to get up to the maximum level before the caps go in. So there are a lot of things like that going on. I'd be glad to talk about the specific thing later, but I'd need to know a little more.
Sure. Thank you.
Thank you guys so much. And if there's any other follow-ups you have, you can reach out to me for contact information, but thank you guys.